much. I have a great pleasure in introducing the next speaker, a dear friend of mine from Singapore, Jacob. He's going to enlighten us on the topic titled Advanced Application of Lateral Surgery. Thank you, Jacob.
Thank you very much, everybody, and thanks for your resilience on hanging around to hear about lateral surgery on a Sunday. Okay. Let's see. Here are my disclosures. A little bit of background about myself. I started as an open surgeon in 2012, and I started my first lateral cage, lateral procedure, transpsoas, they call it a D-lift, 2014. And when Rick Hines came to Singapore in 2016, that's the first time I actually heard about the ATP or what we call the OLIF procedure. And I thought that it sounded quite nice because a lot of problems I faced was with thigh pain. And then you can see in 2016, I think that was in later part of the year, I went to Bangkok. You can see some of the surgeons over here, you will recall. Warren Watt just gave a talk. John Choi, still looking very young. You know, the funny thing about lateral surgery is a testament that it works is that all these people who are in that course are still doing lateral surgery right now. So, you know, sometimes procedure comes and goes, but these people are all still standing by it. So that's a good thing, right? I did my first olive case in 2016. That went pretty okay. It took me about 4 hours, went quite smoothly. But I will confess to something that probably I didn't tell anybody, but I was still a skeptic, to be honest, in 2016 and 2017. Why was I still not convinced, although I could do it, I went for the courses, that olive was the way to go? Partly because I was so used to my TLIF procedure, so comfortable with it. So I asked myself, for a single level L4-5 spondy, why would I want to do a front and back procedure, right? Because like Jason did a study together with me and Ruben, most people would think that, hey, this is a longer operation time. There's a hassle of the flip. And it had its own unique set of complications, like what I described just now. And so I was actually still doing the majority of my cases using the TLIF in 2016 and 2017. Of course, why not? Because the MI's TLIF is really hard to beat. You know, you get 2 small incisions, 2.5 cm, patients prone, no drain, they're home in 2 days, and it takes about 2 hours. You show a patient this wound, they're pretty happy. You tell them you need another side procedure, they'll be, why do you actually need it? The MI's TLIF for single level really achieves all the surgical goals: neurodecompression, stability, and good fusion rates. So, but I want to take it a step further because at this point of time in 2016 and 17, I like the olive and I like the TLIF, but I was stuck in between crossroads. Should I carry it on all the way? What extra value would the olive give me? Already I said a single level fusion, probably not much difference. But then, as it turned out, I had a little bit of an unfilled gap, a need that was unmet. Because in my hospital, I'm in the central part of Singapore, there are patients who are a little bit poorer, who are living in these flats, they're elderly, they're frail. We have the silver tsunami in Singapore. We got a lot of neglected fractures, degen, scoliosis, osteoporotic patients, and complex adult degen cases. And so the problem was that I had a lot of cases that needed a revision, a 3-level fusion, a burst fracture that required a corpectomy, adult scoliosis cases. And so I needed to find an MI solution. And so it took me beyond thinking that the olive should be compared to a TLIF. Instead, I would think the olive would give me a wider armamentarium to tackle everything. And so that's when I felt that the olive I would pursue and keep on going. And I think it has really helped me. I realized that in my experience, I had less open surgery, less PSOs, less longer constructs, like we showed what Ayush did just now, and less complication. I had less CSF leaks, I had less hematomas, I had less non-unions, and less cage backouts. So when we talk about the olive and TLIF debate, when a lot of people who are starting out, they will ask me, hey, you know what? I can do the same TLIF just as or even faster than an olive for a single level fusion. And I would agree. And I would think that's a great procedure, do it. But I feel that the great part or the extra unique benefit of the OLIF is when it comes to the indirect decompressions, revision cases, when you do multiple MI fusions and deformity correction. And that's where I would take it that the OLIF improves your armamentarium in comparing both OLIF and TLIF. And that's why I would think that advanced application for OLIFs is really what distinguishes this from other interbody fusion cases. So I'm just going to share a few examples of how it has helped me with my practice. 5 cases. The first one is something relatively common, I would say. This is a multi-level MI fusion case. 79-year-old lady who's got a mild degen scoliosis, nothing very significant, but she's got significant pain. And you can see from the MRI scan, there are 2 levels that's very, very tight. L2-3, there's a bit of gas. And so for this patient, I did a 3-level interbody fusion. And so to do a 3-level MI's TLIF or 3-level endoscopic TLIF, it's possible, I guess. But the concern is whether you leave the patient with a flat back, fusion rates. But a lateral surgery makes it so much easier. And here she is, just a few stab wounds. And on day 4, she's walking around and blood loss is minimal. So I think the lateral surgery really helps, especially in multi-level MIS, multi-level stenosis when you want to do it MIS. Another thing that's really helpful, I find, is revision cases. Now, when you do lateral surgery, you would love to see these cases. I wouldn't say you love, but I mean, you have a set piece, a winning formula when you tackle a case with an ASD. You need to revise them. Now, this patient had a 2-level fusion before, and now on the top level, he's got stenosis. And you can see on the CT scan, there's gas, bone on bone, and there's a nice rock-solid PL fusion 3-4. So how would you deal with these cases today? Conventionally, I guess we would make a long open incision, look at the implants, and then there'll be extensive muscle dissection, bleeding, lots of scar tissue. You may need an O-arm to look at your anatomy to put screws. And even when you can retract the nerve root through that scar tissue, you want to put a cage, you might find you have only a smaller cage and you don't have enough bone. So there must be a better way for this. And that's where I think advanced techniques in lateral fusion helps. You can see we do a total MIS revision for this. We make step incisions on the picture on the left. It's your yellow lines. You can see 1 over the implants where we can remove the end caps and remove the rods, and another 2 on top to put our pedicle screws. And then here's where the robot comes in. Be it navigation or robotic, it's just percutaneous screws. And the next thing I do a lateral procedure, and you can do it a direct lateral, true lateral, or from the side, doesn't matter. This is a prone lateral, and I use navigation as well to help me put in my cage. And then percutaneous screws, you can see only 1 set of screws on top, and I tunnel the rod through to meet the previous screws, and so I can avoid open surgery. And that's how it looks like. And that's him with 200 mils blood loss. I think the proof for the pudding is that the patients actually do okay. You can see his previous incision is right down in the middle. Now I got 4 step incisions, and he's walking on day 1. So lateral surgery has really helped in terms of ASD and revision cases. Here's a 1 year. You can see complete fusion. Another case that we see regularly is these osteoporotic burst fractures. Now, how will you manage these patients? She's 76 years old, osteoporotic burst fractures, got a T-score of -2.5 to 3. Can't remember the exact figure. But yes, I think it's possible to do it from the back, and you can do put a cage from the back, but you might have to go a bit longer down to S1. You may have to do it open. There'll be probably a little bit more manipulation of the neuro elements. And we don't want to do that for these old patients. Lateral surgery can shorten that construct, and it can be done MIS because you can also do a direct decompression from the front. And this is what we did for this lady. She's now 2.5 years out. And again, the setup using the robot, and we put the downside screws, the upside screws. And this is the view that you would see when you're doing the lateral approach. So the lateral approach, you do a discectomy at 3-4, discectomy at L4-5, and you can see there's the thecal sac down there nicely visualized. And what's coming up on top over here is actually the exiting nerve fluid come up here. And then you put a cage. This is a nice expandable cage, one of the best in the market. And again, she's able to walk on day 4, clearing some obstacles. This is the TTSH obstacle course. Okay, and at 1 year, she's nice and fused. Another case that lateral surgery has really made a difference is in adult spinal deformity. Granted, this is a very mild curve, but the main problem was not because of the curve. The main problem was because she's got multiple level of stenosis, L4-5, L3-4, L2-3, L1-2, and all the way up to T11-12. So because of that curve as well, we decided to instrument her from T10 to the pelvis. And there's many ways to do it. In this case, I use patient-specific rods where I will upload my x-rays into my phone, into an app, and then they'll calculate all these parameters for me. So my resident is pretty happy. I don't know whether it's a good thing or bad, but he it's important for him to measure it out, the figures, but now he just copies it down, right? And then we come up with a plan of what SVA we would want and where we're going to put the interbody cages. You can see some interbody cages down here, here, and here. They send us the rods. These are pre-contoured rods, and we merge it together with the robot. And this is where lateral surgery steps in, right? Lateral surgery allows you to stage the procedure, and staging has its benefits. You don't get such a long surgery. The hit on the patient is less. You can reassess them. You can reassess their balance. You can reassess whether they need a further decompression. But to do a circumferential MRI procedure, you need to have lateral cages in front. Otherwise, you'll be doing open cages, putting cages from the back, which is an open procedure, right? And you can see this L5S1 ALIF. And then we do percutaneous screws and we tunnel that rod through from T10 all the way down to pelvis. And you can see once the towers are off, extenders are off, everything is all percutaneous. And you can see you keep the muscle envelope intact. And that's how she looks like. Again, MIS correction, it's really lateral surgery helps you to do MIS, long construct deformity correction, but the prerequisites are these lateral cages. And here she is. This, I think, is day 3. The reason I put a drain in, you can see there's still a drain, is because sometimes they get a seroma, which you have to manage it. Okay. And in my last case, I think those previous cases were all about MIS cases. This is an adult deformity case. Now, I think you can do this everything from the back as well, but lateral surgery is a very powerful tool that helps you to perform anterior releases. And then when patients is very, very kyphotic, you really want to get those cages in front, right, to at least do the releases and actually get some lordosis. You can see here, rib on chest phenomenon. And you can see the asymmetrical disc spaces, and you can open that up. And this is a little bit bigger because it was on the convex side. And you can see the psoas and 3 cages are inside down there. These I did about 3 years back. And then the rest is probably a long construct, 4 rods with a kickstand rod. And then this is how she looks like. Just to highlight the benefits of lateral surgery in bigger cases as a release and helping to correct lordosis. So in summary, I say OLIF has multiple benefits. It improves your armamentarium, not just for the smaller grade 1 spondy cases, but also for the bigger cases. I think selecting the right procedure can really help you, especially when the patient needs it. So with that, thank you very much. And happy to take any questions.
Thank you, Jacob, for your wonderful lecture. We'll take questions or comments from the audience. I'll start off. It's just a small thing I wanted to question. Was that in case one, I could see that on an X-ray you had a deep drain in. Is the drain you use it routinely for multi-level lateral constructs, or was that simply for that patient, or did I see it wrong on an
Usually for
X-ray?
3 levels, I tend to put a drain. Just because usually there's about 50 mils output. Sometimes I don't if it's very, very dry, but I've been been quite used to putting drains in.
Can I ask everyone who were speakers, and obviously including the moderators, whether
Okay.
retroperitoneal drain is something they use routinely?
May I question, okay? So, thank you for the great presentation. And so, I agree that multiple stenosis or sclerosis cases, maybe the LRIF is a very good indication, I think. So, I agree with you. And so, I have a question. The corrective fusion surgery cases, you preserve the back muscle, but so many cases have the needed the facet cutting. So, how about the indication of the muscle preservation? So, so inferior suspended cutting cases maybe are there. So how about your indication of the muscle preservation surgery?
Sorry, I'm trying to, are you saying that when would I do open surgery after my lateral
Mm.
surgery? Okay.
Yeah, yeah,
So
yeah.
to preserve the muscle, that's a great question. I always try to keep the muscle envelope intact and I try not to open it. The times where I would try to open it is when I think I have to do an osteotomy or do more releases.
Mm-hmm.
And typically after my first stage, I'll lie the patient down supine and I'll take an X-ray. And if I find that the deformity is not very significant, and I can use and the screws and the osteoporosis is not so bad, then I'm quite confident to use my screws to reduce. Then I will not do an open procedure. If the patient is very, very severe osteoporosis, I will be more hesitant to use the screws to manipulate that spine.
Mm-hmm.
Yeah.
Oh, thank you so much.
John, going back to your question, I'll be honest with you. Actually, I did a 3-level case a few days ago, and I didn't put a drain because I know you told me that you do not put drains. So does the rest of them put drains? Because I have been putting drains, and I don't know what everybody's experience is as well. I'm curious. Yeah.
I don't put drain in, but yes, I sometimes see the chymosis after surgery. Maybe I didn't stop the bleeding from the peritoneum fat good enough, but normally I didn't put any drain in. But yes, sometimes you have to monitor for the hematocrit to drop because it occurs in the retroperitoneal area and you cannot see it.
Even for 3 levels, no?
No, no.
Okay.
Yeah.
I usually routinely insert the drain because I think the hidden blood loss is in the retroperitoneal space is a little larger than we think. So if you check drain is not too much, but the hidden blood loss is retroperitoneal space is a little bit large. So olive is sometimes a little quiet blood loss. So you check the hemoglobin loss for routine lab during the lab. So I published the hidden blood loss after olive. So I think I routinely insert the drain after olive.
I usually do not do so actually, even after 3 or 4 levels. I think I do believe actually in a bit of tamponade when it comes to post-surgery. So as long as we on the way out of the retractor, you can see that there's not much bleeding, I will not put any drain. On the occasion that I see a bit of oozing, I do put a bit of hemostatic agents. I stop it for a while and I have a look again. And if it's not oozing much, actually, I will not just, I usually do not put drains as a result. Yeah.
To answer John's question, yes, Yeah, before I met you and discussed with you, I usually put the drain for 3 to 4 levels of discectomy. But right now, I'm stopping putting drains. I only put drains in corpectomy or infection cases. And I have one question for Jacob. For the lateral corpectomy cases, do you go transpsoas or anti-psoas? How do you manage the psoas muscle in the L4 level?
Yeah, great question. Anti-psoas. Anti-psoas. So I would say that I just create that corridor. I mean, 3-4 is very easy to push it back, and then 4-5 as well. And once 3-4 discectomy is done and 4-5, the psoas tends to move a little bit more. And so a quick 3-4, then I release the retractors, 4-5, release the retractors, and then I put the retractors back in, and then I pull it all the way back to see that pedicle, right? The pedicle is the limit, and then the psoas moves behind the pedicle. The pedicle, I take a Carrison and cut a 4 Carrison usually is okay to take down the pedicle, and I'll see the canal, and that's when I'll start my corpectomy now. So it doesn't really have a problem with that, although I am mindful and I do have neuro monitoring, so I'm constantly checking. Yeah.
We have one question
Thanks.
from the audience to Jacob, which is, how do you prevent femoral nerve injury when you're doing an L4 corpectomy?
Similar to what Chris said, I think the main thing is, first of all, pre-op evaluation. I look at that psoas. Now, is this a very high riding psoas? If this is a very high riding psoas, I'm worried about my retraction time pushing that psoas back because the plexus is a little more interior. So in this case, you could see it wasn't that interior, so it was a regular psoas. The second thing is that I use neuro monitoring and I don't try to keep it there the retractor at one spot for that entire time. I do 3-4 relax, 4-5 relax, and then I pull it back. Yeah, good question.
Okay, we'll move on to the final talk. I have a great pleasure of introducing Yucheng Ye. He is a wonderful surgeon from Taipei that I had the pleasure of visiting in the last 2 weeks.